Are we ready to go, Karen? Yeah. Thank you. Thanks, Emma. And I think Vicky Gray, who is our head of safeguarding with a particular interest in rough sleeping, homelessness and asylum seekers, might join us as well. But I know, Karen, you circulated quite a lot of information yesterday, including the report that Vicky and Elaine Goodwin have pulled together. So, as you said, Emma, very topical at the moment. There's loads of data and information in the pack. I won't go through all of it. And we'd been thinking about doing something on migrant health, vulnerable migrant health, for a while. So, in a way, it's quite good timing. And the reason why it matters, so I'll just give you 3 or 4 things, really. The current position in the southeast. There are some links with rough sleeping and homelessness in terms of risks and potentials, sadly, of vulnerable migrants also being homeless. I couldn't help but put my contract manager hat on and go back to the statutory functions, because I think that sets the scene and that tells us what we have to do as a minimum, but also it gives us the message to help with others in our systems, in our stakeholders, and say we have to do this because it's a legal responsibility of ours. And then some key points around primary care. So if I start with the current position in the southeast, we have seen over the last 15, 18 months a huge change in picture. And the best way I can describe it was, I guess, in particular around asylum seekers. If you can picture a bath with a flow and then a kind of void at the end, there was a continuous stream. And when the first lockdown came in, a plug went at the end, the flow carried on, and that bath has filled up and up and up. And there's some numbers in the slides. At some point in the year, last year, there were 14,000 newly arrived asylum seekers contingently accommodated in hotels across the UK. And these people, some of them are still in hotels, because to be able to move people from contingent accommodation into more permanent accommodation takes time. So we have 2 main factors, I guess, that signal a real change in position in the region. The first one is a combination of vulnerable migrants that all have a different status. So some of them are newly arrived and newly arriving to the shores of Kent. Some of them have been in hotels or in dispersal accommodations for a while and are waiting on the outcome of their applications. The objective for the Home Office is to give that outcome within 6 months. We know that in reality it takes years, I want to say, sometimes if the appeal route is being used, and that has implications on health, in particular mental health. And then very topical, we've got the Afghan resettlement programs, and it's a bit confusing at the moment because some people are refugees, some are evacuees, some might be Afghan, some might be from other nationalities. So it's quite a few people arriving very quickly. And then there's some information, not very much, on the Hong Kong British Nationals Overseas Resettlement Programme, which was launched in January. But again, a group of people who will be newly arrived to the country and will need some healthcare. And then there's changes in the kind of how the spread of these people are. And how the infrastructure to be able to support them is either ready or emerging or not there at all. So I guess we have a combination of some very large, very visible facilities, and the hotels are some of them, and they create immediate and obvious pressures on local health and care services, but also obvious risks for the population housed in them. And then there's some smaller facilities where people might be invisible to local services and agencies. So numerically, in terms of people in dispersal accommodation, we've almost doubled the numbers. So from about 600, 700 people in May 2020 across broadly Southampton, Portsmouth, Hastings and Brighton, I think, were the main dispersal centres. We've gone to about 10, 12 maybe more areas, largely medium-sized town, with 1,300 people. And then in terms of the contingent accommodations, we've got about 600 people at the moment across 7 hotels and Napier Barracks. And I think about 500 people is in an extension of the reception centre in Dover, and then some people in overflow dispersal accommodation. So that's quite a large number of people when you add them all up, and they're not in the same place, and they all have a number of needs. So going to the statutory requirements, if we start with the Home Office, actually their statutory requirement is to avoid homelessness, and it's to make sure that asylum seekers who are destitute and homeless are temporarily accommodated, that their transport is provided to take them from wherever they arrive, whether it's in a port, through lorries or trains, whether it's on the beaches in Kent, or in an airport, to appropriate accommodation, and then provide them with cash subsistence support, toiletry, clothes, food, etc. So that's the statutory requirement of the Home Office, and it explains sometimes the pace at which hotels have been stood up, because if there's been a big arrival, then a roof had to be found quickly. And then for the NHS, there's a couple of things there. So there's a universal part of the NHS, so anyone on UK ground has free access on the basis of need and not ability to pay to primary and emergency care. And the ability to pay is a key one, because the means test applies. So there's a long-winded process to fill in an HC1 application and then receive an HC2, basically exemption of cost certificates. And there's a group of people that are added there that have free access to secondary care as well, just by the nature of their status, and many of our vulnerable migrants would tick one of those boxes. So it's really important to remember that people have a right to access care and free care. Sometimes well-thinking practitioners, and I'm thinking dentists or pharmacists in particular, say, oh, well, you can get that over the counter cheaper, or if you cannot show me your exemption of cost certificate, I don't want you to be fined, so go and get it and then I'll treat you. There's always a box on the FP10 or FP17 for a dentist or a dental practice or a pharmacist to say, I've given something for free, I couldn't see the certificate, but care or medicine shouldn't be refused on the basis that the certificate hasn't been seen. So I think that's quite a key message. And then something that underpins the work we've been doing for the last 18 months, which is that the Health and Social Care Act, which is about to be dismantled, did introduce a legal duty to reduce health inequalities, and that's really key to think about. Unless we start with a thorough health and care assessment and know what people need, how can we then demonstrate that we've tried to reduce inequalities? And if you go straight to the primary care slides, Karen, there's been a big campaign to say general practice is open to all. You don't need to show proof of address or ID or anything. There were some links to letters in the email that Karen sent yesterday to say, here are some guides and letters to be able to vaccinate people without an NHS number. The Doctors of the World have put together a safe surgery toolkit with lots of resources that are specifically targeting vulnerable migrants, so helping practices offer a safe environment. And what's key there is accessible information. So we cannot just assume that because we've made an offer of an appointment, someone has understood or received that offer of appointment. With vulnerable migrants, asylum seekers in particular, there is a level of mistrust, I guess, and thinking that official people that they may be directed to might be the long arm of the Home Office or might have an impact on their asylum application and the decision. So making sure that there is accessible information where people are in hotel, working with the hotel staff to make sure that the information gets to the right people and isn't just stopped at, oh well, they should have gone to the reception and got their appointment, and tailoring expectations on both sides. 2 weeks ago, I think in Reading, we were hearing how a couple of practices had set aside a whole team to provide assessments to people in a hotel, and they had 50% DNA rate. And obviously they were quite frustrated that they put those resources there. But it is really working with the people in the hotel and trying to make sure that people knew what they needed to do, where they needed to go to. And sometimes an outreach offer is much easier. Because people can see that you're coming to them. And I guess that's my last point. I know that there's been a lot of people taking their fate into their own hands and thinking, well, if I go to the hospital, then I will be seen. And it goes back to that communication, accessible communication and trust. A hospital is quite a known, accepted building, establishment, whatever country you come from, and seeking care there is an easy way to think there will be people who can help me. So again, thinking with as a commissioner or system hat on, working about how do we offer the best care, but at the same time channel people in a way that they get the care they need and that is appropriate to their needs, but don't necessarily go to A&E because they've got a bit of tummy ache or they don't know where to go. So the final point I wanted to say was around reimbursement of costs. There is additional funding for those additional screenings and tests that would normally be offered in initial assessment centres, 6 of them across the UK. So all these hotels, most of them are contingent initial assessment centres, to offer, and it's really an offer, it's not compulsory, the full spectrum of screenings and tests that might be needed. And for the Afghan bridging hotels, it will likely be the same reimbursement route. So I think I'll just leave it there, and then maybe Terry, you can take us through the public health element. There's a big section on mental health, which is quite key, but no time to go through this now.
Thanks, Olivia. There are a few questions in the chat box. It might be appropriate to address those now before I go into the public health section.
Yeah, thanks, Terry. I was just going to mention that. So there's a couple around fees and finance, Olivia, that might be useful to pick up. So Daniel has asked, are you able to explain the prescription fee specifically for the Afghan resettlement scheme at all? It's been a problem for them locally.
I'm not sure it's specific to the Afghan resettlement, so it's that HC2 exemption of cost certificate. It takes a while to obtain, and I know a year ago nationally, when we had hotels with homeless people in, we were trying to have the hotels as a site that is exempt of cost, but a bit like care home, but it takes a long time. So for the Afghan resettlement, it might be a different position because of the means test. I'll look into it, I'll come back whether it is, but I suspect that people who fled their country in the conditions we've seen haven't come with, cash in their pockets to buy a box of paracetamol over the counter. No. So that might need to be prescribed.
Yeah, Helen, did you want to come in on that?
Yeah, so I think I agree. It's not just the Afghan evacuees. So we currently have an IRC centre that's been set up in Surrey Heartlands, and actually we're having that same problem. So these patients are actually only in the area for 24 to 48 hours. So they are not required to register temporarily or with a GP practice. There is obviously support from the Home Office for the nurses, but of course the nurses can't prescribe. And the question is then, how do we get prescribing costs if we want to put some primary care wraparound for these patients? Because of course there's no NHS number, there's no registration. So I think we're having a real difficulty in that area. And even if they turn up at the walk-in centres, you know, they're not going to get necessarily that without an NHS number. So we are really struggling in Surrey Heartlands with it.
Yeah, and Jackie's mentioned some challenges around access to NHS dental services and issues around NHS numbers because of lack of information and things as well.
Emma, shall I take those two back? Both the
That would
prescription,
be
because the means test was simple enough for the asylum seekers. It becomes more complex when we talk about all sorts of refugees and evacuees, and the dental bit. And Andy made a comparison with the Syrians. So that is still the case, but because we've been working through that reimbursement route for the contingent hotels for asylum seekers, the debate at the moment is, do we give each area that is concerned a £600 flat fee and things might change, or do we continue with the reimbursement of actual costs? So the principle is there, the mechanism is being worked through.
Brilliant, thank you. Let's go on to Terry and then we can carry on with questions if any more come up around that at the end. Terry.
Okay, thank you, Emma and Olivia. So what I'm going to take you through is just some observations and some considerations regarding the health of migrants. And of course, there will be people on the call who have additional insights to share. Hello, Wendy Malkinson. I'm sure you can contribute as well as we go through this. I think the first thing to say is that getting live real-time data on the health of migrants is quite complicated. One, because migrants, as the term covers a huge spectrum of non-UK born people now living in this country, and within that you've got refugees, asylum seekers, students, people coming here to work, people coming to join families, etc. And if people are registered and on systems that particularly general practice, that's great. We can monitor their health, but there's no coding or flags at the moment that helps us to identify people who are refugees and asylum seekers, and that's not collated at a national level. So the data sources that we draw upon are the annual population survey and the labour force survey, which have limitations. So what I'm going to present to you is an insight based on the data that is available. So the first thing to say is that when migrants arrive in this country, they are on average healthier than the UK-born population. That's because when they arrive, they tend to be younger, and they tend to stay. The younger people tend to stay longer and not return back to their homelands where they originally came from. So 27% of the foreign-born population in 2019 said that they had a long-lasting health problem, which is 15% points lower than the UK born average at 42%. Another important factor is that migrants in low-skilled jobs were more likely to say that they had long-term limiting health problems than those in high-skilled populations. And that is true for the UK-born population as well. It's one of those structural factors related to determinants of health and health inequalities. People in lower-skilled jobs have fewer opportunities, perhaps educationally, to move on. They have because they're on low pay and having multiple occupations, there's more stress that comes with that, perhaps not being able to afford foods, etc. So no surprises that migrants in low-skilled jobs say they have long-term limiting health problems compared to those in higher skilled populations. And migrants who've lived in the UK for longer are more likely to have health problems than those who arrived recently. So what the data clearly shows is that there is a migrant health advantage for when migrants arrive in the country because they are a younger population and they're generally healthier than the UK-born population. But over a period of 10 to 15 years, their health reverts to the norm of UK-born people. And a lot of that is to do with lifestyles and what people eat and drink, etc. So they end up being like the rest of us over 10 to 15 years. And the share of residents reporting a long-lasting mental health problem is 5% for the foreign-born and 10% for the UK-born. But again, please remember that this is for a wide spectrum of migrants. When you then focus down on specific groups, like asylum seekers, we know from our direct experience here in the Southeast that people who are fleeing conflict and war, torture, harassment in its various forms are often traumatized before they arrive in this country, and that experience is lasting. So our experience with Napier Barracks is that, of course, there are people with mild to moderate mental ill health, but there are also those who are experiencing post-traumatic syndrome, which requires specialist support. Okay, you can move on to the next slide. So asylum migrants are more likely to report a long-term health condition. So this is true with asylum seekers on their arrival. They tend to have more long-term limiting conditions right from the start. So their health outcomes are poorer than other migrants and poorer compared to the UK-born residents. And that is from the evidence so far throughout their lives. So this has implications, and particularly in terms of enabling people to get into the workforce. Really, we need to get their physical health and mental health supported before we can have any expectation of them sustaining meaningful employment. The other thing to say is that there are perceptions in the media that outsiders, migrants, are bringing ill health into this country from infectious diseases. This is absolutely not true. Can you press the next slide? Is it a little bit? Yeah, there we go. It's a tiny, and again, please. There should be another bit that's added to it. There we go. So the burden of infectious disease is tiny for migrants compared to the UK resident population. And next slide, please. Of course, for migrants coming from some specific countries, there's a higher prevalence of specific diseases like tuberculosis, HIV, malaria, and enteric fever. Next slide, please. And why is this the case that migrants do have an undue burden of some diseases? And if you can click that twice, please. Some of this is due to the country of origin, where there is a higher prevalence of specific diseases. It may also be related to socioeconomic conditions in terms of poverty, poor housing conditions, cramped living conditions, and poor access to healthcare. It may be the journey that exposes them to ill health, being in close proximity to other people as they're traveling in extreme unhealthy conditions. And of course, it may also be related to their experience when they arrive in this country, not understanding their rights of entitlements to services, and indeed those services that they may try to reach, not understanding the rights and entitlements for migrants as well. Next slide, please. There is a wealth of guidance that is available. You can click on any of those links and they will take you through to a wealth of helpful data, including, very importantly, NHS entitlements. And there's specific guidance on numerous communicable diseases as well. Next slide. And finally, just in terms of the context of the experience of COVID, guidance has changed again. So the Home Office are re-allowing the sharing of rooms for unrelated adults. So not all the health measures that we in PHE would like to be seen to be put in place can be applied, but still you need physical distancing where possible, ventilation, hand hygiene, testing, contact tracing, surface cleaning, and the key really is to get people vaccinated for COVID ASAP. That's really as much as I want to say. I just want to check with Olivia if there's any additional insights you want to offer, because you and I have been working very closely on this for well over a year.
I don't think so, and Vicky's joined us, so I think if we have a few more minutes, maybe Vicky, if you want to share some of the top safeguarding risks from the work you did last year, and some of the presentations or circumstances we've seen in some of the hotels. Not wanting to put you on the spot.
No, that's fine. I don't mind being on the spot. So in terms of safeguarding issues, unfortunately, they are many and complex in their nature. A lot of our safeguarding issues stem from also an issue around interpreter services, is ensuring that there are correct interpreter services in place for migrants. But the vulnerability that migrants experience in a pre-migration context and in a post-migration context can come from vulnerability around gender. So we often see particular issues around women and girls in terms of sexual violence, in terms of slavery and trafficking issues, which we also see with young men. And older men. So very significant issues around slavery and trafficking. So you've either been victims of slavery and trafficking pre-migration, or additional vulnerabilities once arriving in the UK to being targeted for slavery and trafficking. And that includes county lines activities as well around sort of drugs and things. There's also a significant issue around child benefit and being exploited financially, economically, around women having children and coming here and being used to take things like child benefit away from people. So they're quite significant issues. The issues we've seen in the hotels in particular are around the initial health screenings, as I say, making sure we've got interpreter services, trying to separate out who is actually with somebody who might be abusive to that person and seemingly being in a relationship at the same time. So whether that person might be a trafficker or some kind of abuser who's arrived with that person, or somebody who is in a relationship where there is significant domestic abuse going on within that family. Also issues around people with learning disabilities, because in a pre-migration context, people may be very adept at hiding a learning disability. So it's very difficult to assess, particularly in a primary care situation, whether somebody is significantly traumatized, is whether somebody has an educational sort of deficit that might affect their ability to understand and answer questions, or whether somebody actually has a learning disability. And we've had feedbacks from some very experienced NGOs who are really used to working with people seeking asylum, who are saying it is extremely difficult, even with their wealth of expertise, to try to unpick significant trauma and sort of educational ability versus an actual learning disability. And we've seen some very sad examples in statutory reviews of people who have been trafficked here who have a learning disability. And our response has not been great, hence the statutory review and learning out of that. But I think the overall consensus in the literature and the evidence is around the fact that we just simply don't know the extent of learning disability amongst this particular cohort. The other, just to finish off, because I won't take up too much time because I could talk about this all day, is we are quite concerned as well about the sharing of accommodation, completely understanding the fact that there is this immense pressure on accommodation and being able to provide accommodation for people, but making sure that the risk assessments for people sharing is not just based on infection control. It is actually based on whether people have particular vulnerabilities, whether there are mental health issues, and what risk assessments are actually taking place for people to share. Another really significant issue that we're seeing is around pregnant women and the amount of movement that people can have between placements when they are either about to have children, their baby, or in the time after the baby's born. And again, we've seen some really horrendous child safeguarding reviews where we've seen that the movement of people from place to place, having to try to retell a story, the re-traumatizing of that for the mother, the lack of the difficulty and the danger of people getting lost in the system, have led to some very tragic outcomes, including deaths of babies, where mums have then gone and left their babies with an unregistered childcare in a facility where they've been staying in order to go and try to earn money, possibly in things like nail bars and stuff like that. And sadly, the baby has ended up being killed. So I'm happy to share the links to those reviews that I've mentioned that talk about that movement of pregnant women and the issues around that. So I mean, that as I say, there is a wealth of safeguarding issues that we could talk about. But I think one of the key things is ensuring that where you have people placed in hotels or other accommodations in a particular area, that the safeguarding partnerships, the Safeguarding Adults Board and the Child Safeguarding Partnerships are notified through their chairs and business managers so that they can sort of understand what's going on in their area and hold that multi-agency work and ensure that all partners are communicating well with each other and supporting the families, young people and single adults that come over. And particularly in relation to sort of proactive work by the police as well, looking at the relationships around keeping safe with people who are here seeking asylum, and making sure that they know how to report to police and that police are non-threatening to them versus the police from where they may have come from. And also whether there is possibly more of a police presence around that facility as well. Based on the fact that we know abusers and organised crime are very quick to target areas where they know there are very vulnerable people who are ready to be exploited by the more unsavoury people in society. So they're the kind of key issues that we've seen. One final additional point to that is the work around prevent. And we know from going round to the various areas who've taken people seeking asylum, that there can be a real increase in community tensions around that. So there is a risk of far-right extremism to think about, and there is also a risk of extremism within the cohort of asylum seekers that have arrived, depending on their experience, depending on their vulnerability to extremism and grooming. And whoever may pick them up to exploit that. So it's really important as well that we don't forget the prevent agenda around sort of extremism and know how to respond to that, and that the workforce is appropriately trained and able to do that. So as I say, there is an absolute myriad of things we could talk about, continuing on from things like safe sleeping, right through to domestic abuse, but that's just a sort of snapshot. And I see that our paper has been attached today as well for people to read, which has got a lot more of a comprehensive overview of the things that we found talking to people up and down the country, as well as reviewing the existing literature that's around asylum seekers at the moment. So I hope that's helpful, but happy to take any questions because I wasn't expecting to give a spiel, but I hope that was helpful.
Yeah, that was really helpful. Thank you, Vicky, putting you on the spot. That was brilliant. I'm very impressed. Did you want to say there were a few slides, I think, Olivia, that were around the Hong Kong bit? Should we just let colleagues look at those in their own time? Or did you want to pick out anything in particular?
Well, starting a habit of putting people on the spot, I was wondering whether the answer to Andy's question is to bring Roy and introduce Roy to people who don't know Roy, but Roy is starting to know quite a few of the people on this call and other calls. So, Roy, if you could explain what the Strategic Migration Partnership does, so that it provides, I guess, an awareness, but also some reassurance that those hotels don't appear overnight with people without any infrastructure or communication around them. And your organisation has got a pivotal role in bringing all the multi-agency partners together.
Yes, thanks ever so much, Olivia, and my apologies for being late to this meeting, and it was exactly for that reason that I was a bit late, actually. So yeah, the Strategic Migration Partnership, we are funded by Home Office, but independent of Home Office. Actually, we're one of 12 partnerships that cover each of the 9 English regions and the devolved administrations, and we're set up, I suppose, in many ways as a conduit between the centre and the local when it comes to key migration policy and issues. And we for a long time, we're kind of, concentrating on being able to reflect back to the centre what the impact of migration is at the local. And we still do that work, but we've been very much more involved of late on a number of key migration programs, all of which you've referred to here today. So the Afghan, the ARAP program, the Afghan Relocation Assistance Policy is what's clearly a key priority for us at the moment within our relatively small team, and that's involving the use of hotels. I mean, as people are managing to get out, although let's see what today's news brings. We're working with local authorities to provide and hope that the local authorities can provide more permanent accommodation at the earliest opportunity. But the need is such, and it's so big that people are in the main going into quarantine hotels and then into sort of bridging hotels before their accommodation is found within a local authority area, and there are many of those across the country. And in the southeast we have a number of those too. So I won't try and recite them all because I'll probably miss them. But so, for example, 2 in Milton Keynes, one in Eastleigh, one in Canterbury, and the list grows. So there's a huge piece of work about making those introductions to the local authorities. We'll get a heads up from the Home Office that will say we really need that hotel in that area. Who do we speak to and how do we get in contact? And we provide that mechanism for doing that. And sometimes we can instantly kind of give some steer about whether in fact you should or not do that. So for example, if it comes to somewhere like Slough, where there's been a huge amount of pressure, and Reading too through the asylum side, is it really going to be that productive to have a conversation on hotels for Afghans at this moment in time as an additional kind of thing in your area? Perhaps there is no option. I mean, because we are in that place, but we'll give that sort of support and advice around that. So on the asylum side, hotels, again, I mean, everything sort of is sort of hotel focused at the moment because there isn't enough asylum dispersal accommodation. There was through COVID, there just simply wasn't enough, and no opportunity or very reduced opportunity to bring longer term asylum dispersal accommodation, typically a sort of dwelling or an HMO where someone would live for, more permanently until they get a decision on their asylum claim, sort of 6 to 12 months, sometimes an awful lot longer. So those hotels came on in rapid succession during the peak of the pandemic, and they are doing so again now, actually. And that's mainly due to sort of intake levels, not exclusively small boat arrivals, but that tends to be what captures the public imagination because it's so visible, of course. And at the moment, there is also a pressure on the Immigration Removal Centre estate, and 2 hotels in the southeast have been brought on to act in that space as well. And that can sound it sounds actually in a way more punitive than it actually is. Actually, people are not going to a hotel to be kind of in the environment of an immigration removal centre, but they're being filtered through to those centres whilst they are going through day 2 and day 8 testing, and then found another hotel somewhere else, actually. But it is a non-detained environment. So all of that is happening. On the unaccompanied asylum seeking children front, something else which we coordinate across the southeast. The new rota was launched back here last month. A rota of regions who would nationally take a turn in placing children in authorities who are deemed to have space. There is a calculation that sits behind that, and in our region, it's out of the 19 upper tier authorities. There are 17 that have got space, and 2 that have been really over their 0.07. So Kent, Portsmouth was not any longer, and Brighton is. So trying to place children within this same environment of finding these kind of collection of pressures funneling through local authorities in the main at the same time. It's been difficult. And once again, we've seen the use of hotels in that space. So there are 2, one in Brighton and Hove, well, actually in Hove, but in Brighton Hove City Council, and one in Hythe and Folkestone and Hythe District Council under Kent County Council. But Kent County Council are removed from the support of that. That's just where it sits. So an awful lot happening there. And on the Hong Kong BNO side, that's British nationals overseas, the visa means by which people who were registered pre 1997 can come to the UK on that visa. They have to pay for it. It's an expensive route. We are funded through the MHCLG actually to provide a welcome hub. It's a virtual thing through our website, so we can put the link all onto that. At the moment, we are engaged across the southeast in a sort of sub-regional conversation with our leads from Thames Valley, from Hampshire, Isle of Wight, Sussex, Surrey and Kent to both promote the fact that welcome hub is up and running, then to inform how it runs, to give information to voluntary and community organisations who can apply for MHCLG funding through us in the first instance, but we don't make the final decision on that. We also host some area weighted funding, which we are yet to completely distribute because, to be honest, we are still waiting to see where the need is the highest. And I think all of those areas agreed that it wouldn't be sensible to attribute that funding at this moment in time when we don't know where the funding need is going to be, most effectively spent. So we're working at pace on everything actually, but that is something else which has happened very quickly over this period of time. It's difficult to give us numbers actually for the southeast. We have our best intelligence is coming through soft intelligence actually through community support organisations. As we get more information out there, we're making a range of contacts through groups like Hong Kong Brits and Hong Kong Watch and a brilliant one actually through international nurse recruitment, actually from NHSIE. So Florence Candle has been amazing, and it's just really useful to build that level of information up around the support that we should, we can and we should and can be providing for people coming through that route. Olivia, I don't know did that answer any of the questions, or have I just gone on a spiel, which won't be without form?
I think that was great. And Emma, that provides you a transition to Jane. I think if Jane's on the call, I think she is.
It does perfectly. Jane, do you want to give an update from your side of things? And then there are a few things in the chat, but we can pick them up as we go along because they're kind of being answered as we going along anyway.
Hi, yes. So the update is very much health focused because I'm the Health and Homelessness Advisor with the Rough Sleepers Initiative. Obviously, MHCRG are heavily involved around the Afghan relocation and assistance policy, otherwise shortened to ARAP. And that's a letter's gone out to local authorities around move on accommodation, more settled accommodation for people who are coming from Afghanistan. And obviously that is a challenge because the housing's already under a lot of pressure. As we know, there's a shortage of housing. So, but they are working heavily with and closely with the local authorities to try and find housing, and especially some larger houses for families who need to move into them and start settling, which is obviously going to very much help with managing the trauma that people have gone through. Also, we're still having quite a focus around coronavirus, which is especially as we move into the winter months. So encouraging all areas. So we cover 281 areas across England who receive funding from the Rough Sleepers Initiative. So we're still promoting people having both vaccines and also still maintaining the hands, face, space policy, and also the reporting of outbreaks to their local public health teams. So that's still on the agenda. And we're very much working with the areas around their delivery plans for this year. So really focusing on what can be achieved in meeting the needs of rough sleepers and those who've moved into accommodation, and thinking about more longer term accommodation and helping people to settle into communities. And so as part of that, I'm involved in work around social prescribing and the National Social Prescribing Academy. And we also, in those delivery plans, making sure that health is included in the plans. So thinking about GP registration, pathways from hospital, people coming out of prison, and care leavers. And part of my role is also to look into deaths. So they reported to me so we can ensure there's a review that happens locally. So the learning from a death can then be applied where there's change needed or where there's gaps identified that have impacted on an individual, and then that person's died. So it's very much looking at change and transformation. Changing futures. I think since we last met, there's been a confirmation of funding to areas, and in the southeast, both Sussex and Surrey have received their information that they've been successful in their bids, and that's very much about integration and getting systems to work together with that person-centered approach. So yeah, so that's all I've got to say really. The more of the housing, I don't think Marie is on the call, but yeah, so that's what I've got to say.
That's great, thank you, Jane. I might, just before we go on to the public health update, I thought it might be useful just to pick up a few of if there are any burning questions for Olivia, Terry and Roy. There are a couple of comments that it'd be worth just flagging, Steve. completely kind of get your bit about the really short notice and kind of the challenges locally of having to manage a sudden influx of people. And I don't know if you want to ask anything or say anything more on that, Steve.
Just very briefly, sorry, thank you for that. Yes, I'm Steve Haynes. I'm from Surrey Heartlands ICS, the Incident Director currently. It's just really to understand that obviously while we're looking at some of the strategic approaches to all of these schemes, effectively things like the Afghan scheme, the IRCs, we have managed quarantine service hotels, etc. They are pulling on the same pool of NHS resources for their immediate needs at the moment, and that's the particular challenge for us. So I think we're all aware that it's going to take time to take control of these particular issues, especially the Afghan arrivals. But the actual scale of this, certainly across Surrey and Sussex, is significant. And is obviously focused on a very small area with one hospital. So I think it's just to highlight that at the moment we're in the very early stages of this response, and it is difficult, and we're having to do some really quick and dirty work in terms of making sure that these people are getting the care they deserve. But it was just really to just sort of highlight that particular challenge from a, if you like, a frontline health perspective.
That's really helpful. Thank you, Steve. And Andy, just to make sure you've seen Olivia's message about picking